Well, a warm welcome to this video. Now, I had planned on doing a bit of a news update today, but I got a bit distracted with the hydroxychloroquine question, so we are going to do some more on that. And this will be the last time I do it until I have something really definitive to give you, because at the moment it's not definitive. But just to give you the bottom line on this video, if you don't want to watch it, my thoughts are leaning more and more towards the idea that low-dose hydroxychloroquine does seem to have benefits. That's where my thinking's going. It's not yet definitive. To understand why that is, you'll have to watch the whole video. But to give you the bottom line as much as I can, the UK recovery trial, Oxford Centre for Evidence-Based Medicine, and the World Health Organization Solidarity trial, both seem to use a ludicrously high dose of hydroxychloroquine, and I don't pretend to understand it. So we'll look at that in detail. But first of all, just before we get on to the hydroxychloroquine issue and some more studies, a few days ago I did a video on reinfection, this idea that people can have the virus, make a recovery, be better, and then get the viral infection all over again. Now, we did mention a case in Hong Kong where this had happened, and the authors of the Hong Kong study were metaphorically waving their hands in the air and saying, oh, this is terrible, this means vaccine won't work, this means herd immunity won't work, and I don't agree. I think reinfections are going to be rare. But of course, as soon as I'd finished doing that video, there was 2 more cases of reported reinfection in Europe. So let's look at those now. Now, one was in the Netherlands. This is the government virologist in the Netherlands speaking. Viral genomes were different. So as we saw in the Hong Kong study, the viral genome that infected the person the first time was different to the one that infected them the second time. The person reinfected was an older person with a weakened immune system. Marion had been expecting, the virologist had been expecting reinfections. And we have to see whether this happens very often, she says, but I'm expecting it not to happen very often at all. So I'm still not worried about that, but yet this case is there, it's documented, it's official. So it should be mentioned, really. And likewise for the Belgium study. Again, this is the official virologist speaking from Belgium. Woman who got it the first time in March, and she got it again a second time in June. So first infection in March, reinfected in June. And again, these are documented cases. Antigen studies positive in both times. Now, the virologist in Belgium reports that the woman's symptoms are relatively mild. May not have created enough antibodies to prevent a reinfection. That's a strange thing for a virologist to say. Now, I do hope some of you managed to catch that interview we did yesterday with Ragad, Professor Ragad from Iraq, because she talked about the importance of so many other aspects of the immune system, other than just antibodies. So I assume this virologist is just trying to simplify things for the public. They might have helped limit the sickness, so the person had mild symptoms. I think that in the coming days we'll see other similar stories. Yeah, we might see a few. It's not good news. Well, the Belgian virologist is worried about it, but I'm afraid I'm still not worried about it. Because one of the reasons is there's a high level of surveillance already. So if you take a lot of airports, for example, people are getting surveillance as they go in and out. And we've only found these 3 documented cases. Now, no doubt there's been more cases since I've started making this video, but there you go. But there's a few, and I'm not worried about it. I believe, and I was delighted that Ragad agreed with me on yesterday's video, that reinfections are going to be fairly uncommon, that immunity should be long-term for the vast majority of people. And when I say the vast majority, I think it's going to be over 99% are going to have good levels of immunity. And that a single vaccine is going to work. That is still my view. Now, coming on to the hydroxychloroquine thing, this is just... I just need to do this before we put this story down and start looking at so many other important things that are going on in the world. But first of all, I want to take you to the British National Formulary website, and we're going there live. This is it live now on the internet, straight from the British National Formulary site. So Hydroxychloroquine. Everything you want to know about it. We've been using it for decades. Current indications here. This is why we give it. This is the current reason it's used in the UK. And we see the dose, 2 to 400 milligrams daily. It's just unambiguous. 2 to 400 milligrams is the daily dose. So the dose is 2 to 400 milligrams based on ideal body weight. Now let's just say my ideal body weight is a little bit less than my actual body weight. Probably quite a bit less actually, because some of us carry too much fat. So that's not our ideal body weight. So very often drug calculations need to be calculated on ideal body weights, because drugs very often don't absorb into the fatty tissue. They just absorb into the water-soluble muscle and other tissues. So that's based on the ideal body weight, and that comes out at 2 to 400 milligrams for most adults. So bear that in mind. That is the dose. Now, British National Formula then, 2 to 400 milligrams. Now the Belgium study we looked at yesterday did show a benefit. 800 milligrams on the first day, then 400 milligrams each day after that. These are the doses, 400 and 400. So 800 milligrams on the first day, 200 milligrams, 200 milligrams on the second day, a total of 400 milligrams on days 2 to 5. Then the Italian study, which we are going to look at today, again, the dose it gives is 400 milligrams a day. So the Italian doctors gave 400 milligrams a day. What do the British National Formulary say you should give? Oh, look, 400 milligrams a day. So the Italian doctors managed to get the dose right. Now, the Brazilian study that we talked about, which showed dubious results, that had a higher dose. The results didn't show clear benefit at that higher dose from this Brazilian study we looked at yesterday. Now the UK recovery trial, 800, so that's 1600 milligrams. And then 12 hours after that one was given, 16, 17, 18, 19, 16, 17, so it's like 2 grams, isn't it? 2000 milligrams in the first, it's just like a huge dose, isn't it? So then they gave 400 milligrams twice a day for days 2 to 9. So that's 800 milligrams a day. So they're giving 800 milligrams a day. So 1600 milligrams on the first day, followed by 400 milligrams 12 hours after the first dose, followed by 800 milligrams a day. This is the UK recovery trial, courtesy of the Centre for Oxford, the Oxford Centre for Evidence-Based Medicine. Let's just remind ourselves of what the dose is. 2 to 400 milligrams. I mean, am I missing something here? How do we explain this apparently bizarre dosing protocol? I don't know. I can't. It's just, I find it bizarre. If I get back onto the right screen. There we go. So that was the UK recovery trial. But of course, the World Health Organization, you would expect them to get it right. Well, the World Health Organization Solidarity trial, they were giving the same doses as the UK recovery trial. 1600 milligrams on the first day, followed by 800 milligrams a day for days 2 to 10. What dose should it have been? Oh, look, it should have been 2 to 400. I mean, I'm sorry, I'm being sarcastic now, but you know, what am I not getting here? The Oxford Centre for Evidence-Based Medicine and the World Health Organization are giving toxic doses based on my reading of the British National Formulary, which is the definitive guide in the UK. Now the Italian doctors seem to be able to get it right. What am I missing here? It's really very, very strange. You know, when I was 19 years old, I was a second-year student psychiatric nurse. I started off in psychiatry. That's what I started doing. And we had to do a drug round as part of our assessment. And you had to give out a drug round and know about the drugs and give all the drugs out properly. But before you started the assessment, the examiner would say, right, what are the 5 rights of drug administration? And if you didn't get it right, he said, right, that's it, you failed, off you go. So in order to get through to doing the drug round, you had to get that right. And of course, it's the right dose of the right drug to the right patient via the correct route at the right time. So the right dose of the right drug to the right patient via the right route at the right time. Every single time you give a drug, those 5 things have to be right. So of course we all memorised that and trotted it off like a parrot. But it makes perfect sense. So, the correct dose is one of the 5 rights of drug administration. This is what all the second year student nurses in my cohort passed. And yet the World Health Organization and the Centre for Evidence-Based Medicine in Oxford seem to have got the dose wrong. What am I not getting here? If you're from the World Health Organization or you're from this UK trial, from the UK recovery trial, tell me. You sense my frustration. Now let's go on and look at another study. Let's try and keep this scientific, because if we're not evidence-based, we are nothing. Ignore anything I say that's not evidence-based. So this other study here, use of hydroxychloroquine in Italy. So this is a multi-centre study in Italy. And this is a bit like the Belgium study we looked at yesterday. They looked at everything that had been done and kind of put it all together. So very similar to the Belgium study that we looked at yesterday. And we've just looked at the dose that used. Now, the Italian authors, this is published in the European Journal of Internal Medicine, 25th of August, bang up to date. But again, the analysis is taken from studies done or data collected during the height of the pandemic, April, May time, when there was unfortunately plenty of patients around. So the Italian authors pointed out that hydroxychloroquine is immunomodulatory. In other words, it turns the immune system up and down depending on what's required. And Rygard was talking about that yesterday, of course. It's anti-inflammatory, which is good. It's anti-thrombotic, which stops the small blood clots. And there's direct evidence that viral entry into cells is reduced in vitro, in laboratory studies, and in animal studies, in life studies. So, good theoretical evidence that this is a drug worth investigating. There's the links, click on them. Multicentre Italian collaboration, relationship between hydroxychloroquine therapy and COVID-19 in hospital deaths. So that's what the study is looking at. Now, the methods that they used. Retrospective observational study. Now, of course, these observational studies are not as good as the randomised double-blind controlled trial studies that we like, of course. But the numbers involved were large, which we certainly like. So they looked at 3,500 patients from the Italian experience, 33 clinical centres, data collected February to May, that's when the data was collected, during the peak of the pandemic. All had laboratory confirmed diagnoses, and they compared patients who received hydroxychloroquine and patients that did not. So all makes perfect sense. Now, the dose of hydroxychloroquine at all centres was 400 milligrams a day. Well done. They managed to get it right. So they gave the right dose. You've probably memorised the 5 rights now. The right dose of the right drug to the right patient at the right time via the right route. So they managed to get that right. One centre, however, did give 600 milligrams a day. But again, that's nothing like as high as the recovery or the solidarity trials, nothing like as high. And the dose was given for a variety of 10 to 15 days. It was normally about 10 days. That's the link that we'll just like to in the BNF for you to check that I'm not making this up. Now, the results from the Italian study. So out of these patients, most of them received hydroxychloroquine. So the number who received hydroxychloroquine was 2,633, and the death rate was 8.9 per 1,000 person days. Now, this is a strange way for me to measure death rates, but I guess it's just the way it's done in Italy. So it's fine, there's nothing wrong with it. non-hydroxychloroquine group, the 817 patients death rate was 15.7 per 1,000 person days. So significantly higher death rate in the non-hydroxychloroquine group. Or to put it another way, significantly lower death rate in the group that received the lower dose, the correct dose, 400 milligrams a day dose of hydroxychloroquine. After adjusting for propensity scores, in other words, they accounted for the groups and made them equal. And we looked at this in detail yesterday in the Belgium study, so I'm not going to do that again. And they concluded 30% lower risk of death in patients receiving hydroxychloroquine. That was their conclusion, hazard ratio 0.7. And they were 95% confident that figure there was between 0.59 and 0.84. So that's the most likely figure. And they were confident, 95%, meaning this is a statistically significant result. So the Italian authors said hydroxychloroquine was associated with a 30% reduction in death rate. And again, they were 95% certain that the reduction in death rate was between 16% and 41%. Most likely around 30%. Now, the authors said this: these data do not discourage the use of hydroxychloroquine in patients with COVID-19. They're not saying use it. You know, there's not many things that annoy me, really, but well, no, that's not true. There are a few. But one thing that really annoys me is I'm always getting emails, and it's usually from someone that disagrees with you, and they usually start off by saying, on your video you stated that. You have stated that. Actually, if you watch my videos, I've never stated anything. You know, it's just not the way we do. We don't state things. Okay, I will state something. Let me state something as a fact. For every reaction, there is an equal and opposite reaction. Isaac Newton's third law of motion. That's the sort of thing we state. Other than that, I don't state things. And these authors didn't state things either. They suggested this, and I like the way they do it. These data do not discourage the use of hydroxychloroquine in patients with COVID-19. They weren't saying do it. You know, they're not saying do this. That is their conclusion from their study. So, you know, we don't have definitive answers. We sort of strive towards truth. That is the aim. Now, I was going to put this on at the end, but I think it seems to fit here, actually. I'm going to put it on. This is from Gary in Texas. Now, I've no idea who this rum character is here, but what will it be, fact or fiction? You know, we're striving towards truth here. Now, I think Gary must be paraphrasing me, because maybe I said terminological inexactitude, or I might have said that. And this might be something I've said, I'm not sure. No matter the subject, listen to established leaders in their field. Then do your own in-depth study and find the facts, not terminological inexactitudes. What you have then is most likely the truth, or you're getting towards the truth anyway. So, no, I don't state things. Only an arrogant or a foolish person would state things. We lean towards a particular conclusion. Now, the other thing that's slightly annoyed me lately is people are making inferences about my political views based on my view of hydroxychloroquine. That is absurd, and actually probably getting towards offensive. You know, the idea that I would be saying a drug works or not, depending on a political point of view. You know, if you want to email me with that sort of opinion, don't bother. You know, don't bother, because this is based on my understanding of the science. That this has become politicised is ridiculous, unhelpful, could cost lives. Right, enough of my rabbiting on. Now, to balance this off, to balance out things a bit, effects of hydroxychloroquine with or without azithromycin on the mortality of patients. Now, this is a French meta-analysis. I must say, a very well conducted meta-analysis by academics based in Paris. Take my word for it, not a chance. Read it. There they are. Now, having said that, the meta-analysis was very well conducted. But a meta-analysis is garbage in, garbage out. Now, I'm not saying this is garbage, not by any means. I'm saying I don't know. But remember, a meta-analysis is only based on the quality of the study that goes into it. And let me just tell you a few reasons why there's a bit of concern here. So they started off with 839 articles and they only accepted 29 of them. So of all the articles in the world, and of course this is bang up to date. Again, this is the 26th of August. So what this French group seemed to be saying is, well, we're going to reject, what's that, 810 articles. Does that give you the impression there's a lot of low quality publications around? They accepted 29 for inclusion criteria. Only 3 were randomized controlled trials to evaluate the effects of hydroxychloroquine with or without azithromycin, except 1. So why they included that one, I don't know, but anyway, they did. Meta-analysis taking data from many studies. So putting that all together, in the hydroxychloroquine group, they had 11,000 people received hydroxychloroquine for the hydroxychloroquine group, and the association with mortality there was 0.83. In other words, 0.83 is saying that the hydroxychloroquine has a beneficial effect, that you're only 83% as likely to suffer adverse outcomes than if you don't take hydroxychloroquine. That's the relative risk. Now, the problem is with that, it was not significant data. They could not get significant data from that study, so we can't accept that number. We can't say there's a 17% benefit from hydroxychloroquine, pooling the data from these studies, because it wasn't a significant result. So that was the hydroxychloroquine group. Now, the hydroxychloroquine with azithromycin group, they had 8,081 people in that, and they found the relative risk there was 1.27%. In other words, there was an increased risk of mortality with a combination of hydroxychloroquine and azithromycin. That was giving both. If you gave both, the pooled meta-analysis data says there's an increased risk of mortality. And they thought it was about 7% was their estimate. And the control group was good. That was 13,000 people, which is presumably what they compared those against. So their conclusion was hydroxychloroquine alone was not associated with reduced mortality in hospital patients. But the combination of hydroxychloroquine and azithromycin significantly increased mortality by 7%. But of course that was only as good as the studies that went into it, which there are some question marks over. And to be fair, the group themselves were very honest about the limitations of the study. So quite a complicated read, but quite an interesting read. But that's showing that hydroxychloroquine is not working from that data. Now, I went on to the WHO Solidarity trial. Now, this was a bit strange as well. So this is the WHO trial we looked at, where they gave this huge dose of hydroxychloroquine. On the 4th of July, it was withdrawn. WHO withdrew it from the trial, along with these 2 antivirals that they were trying out as well, the Pinavir and the whatever it is. They stopped those arms as well. So they stopped that. These are 2 antivirals that are previously known. And we know the dose in the Solidarity trial was high, as we've already looked at. Just remind ourselves. The dose used by the World Health Organization was 800 and 800 in the first day, followed by 400 and 400 on the subsequent days, when the dose in the national formulary is 200 to 400 milligrams per day. So giving 2 to 4 times the dose. Bizarre. Now, yeah. Right. Now, this is confusing. I spent about an hour. I thought, well, I'll go to the World Health Organization site and I'll download the publication that give the results of the Solidarity trial. And I couldn't find it. So I could find lots of articles from the World Health Organization saying about the study, but I couldn't find the paper giving the details of the doses and the results of the study. I couldn't find it. Now, if you can find it, fine. We know I failed to find things before. But I had a good look and I couldn't find it. And really, that should be obvious. World Health Organization site, paper about results of hydroxychloroquine in the Solidarity trial, click and it should be there, bang, but it wasn't. And I did have a good look around and it wasn't there. So, yeah, it wasn't there. I couldn't find it. I mean, if you can find it, send me it. It could just be me being a bit silly, but it's happened before. But what I did find was there's a country that took part in the trial which has very high levels of openness, and that is Canada. And there's a report from the Canadian arm. And again, this is where we got the dose from, otherwise we wouldn't have known the dose. 800 milligrams BID, that means twice a day for 1 day, then 400 milligrams twice a day for 10 days. Plus, of course, the normal supportive care, which is the only ethical thing to do. Why were they giving what I would consider to be a toxic dose? I really don't get it. And then, of course, I was reminded of this Lancet paper, the Lancet paper that says unable to confirm benefits of hydroxychloroquine. In other words, they were saying we can't say that it works. And then this Lancet paper was retracted. Now, that doesn't happen too often. That doesn't happen too often. And yet it happened. So quite what went wrong there is probably a bit of another story, but that was retracted. Now, just to finish, drugs need to be efficacious and safe. And it just so happens that on the 21st of August, again in the Lancet, there's been a very large-scale study published. Because hydroxychloroquine, sometimes in combination with azithromycin, is used for rheumatoid arthritis. This rheumatic condition that's unfortunately not too uncommon. So they pulled a lot of data for that. Where are we? Yeah. So this was a retrospective multinational cohort, and they had the best part of 1 million patients. They collected data from 956,374 patients, nearly 1 million patients. Pretty impressive. Now remember, this is hydroxychloroquine treating rheumatoid arthritis. This study had nothing to do with COVID-19. But it could be argued, and I would argue that, it gives an indication of how safe or otherwise this drug is likely to be. Because this is huge scale data. Retrospective multinational cohort. Hydroxychloroquine treatment appears to have no increased risk in the short term. Short term normally means less than a month among patients with rheumatoid arthritis. So short term treatment seems to be fine. No increased risk in the short term. Long term is a different story. Appears to be associated with excess cardiovascular mortality. So that's longer term though. That's talking months and years of treatment. Not a course of a week or 10 days as might be used for treating COVID-19. The additional risk of azithromycin increases the risk of heart failure and cardiovascular mortality, even in the shorter term. So even in the shorter term, the combination therapy was shown to increases the risk of heart failure, cardiovascular mortality, even in the short term. So that's saying there's question marks over hydroxychloroquine with azithromycin. but it's saying that no increased adverse effects just with hydroxychloroquine on its own. And of course, none of these studies that we've talked about so far mention zinc, none of them. We really need a controlled trial with arms for hydroxychloroquine alone and hydroxychloroquine with zinc. But this data here would question whether it's appropriate to be using additional azithromycin, because that data there shows this increased risk. We call for careful consideration of the risk of the benefit-risk trade-off, and that's what it always is, a trade-off when counselling those on hydroxychloroquine treatment. So that is on treatment for rheumatoid arthritis that they're talking about. But interesting data set that just happened to come out on the 21st of August. It must have taken at least the last year to put this together. It just happened to come out now. So there we go. Now that's all I'm going to say about hydroxychloroquine for a while. You know, the studies from Belgium and the studies from Italy are large-scale studies. Yes, they're observational studies, but they indicate a benefit when hydroxychloroquine is given at the dose advocated by the British National Formulary. What I think is reasonable to say, therefore, is the correct dose. Okay. Now, Stephen from South Africa sent me a pretty nice video, if I can find him. And it's a patient being discharged in South Africa after being in intensive care, I think for 28 days.